Hey, welcome everybody. Welcome to Addressing Pediatric Feeding Disorders in the Schools, an overview of pediatric feeding disorders. As Dawn mentioned, my name is Jennifer Eggert. I am a clinical assistant professor in speech language pathology at Marquette University and continue to work clinically in the field. Financially, some disclosures: I receive a salary from Marquette University and medical support services. I am receiving a stipend from the Wisconsin Department of Instruction for this series. Non-financial, I am the most recent past president of the Wisconsin Speech, Language, and Hearing Association and the current convention chair. And I would like to thank my friend and colleague, Amy L. Delaney, a PhD, who contributed to some of this content. So without further ado, a little bit about who I am again. I am a speech language pathologist with nearly 30 years of experience working with medically complex infants and children with a focus on feeding and swallowing disorders. I've worked in a variety of settings, including birth to 3, outpatient, home health, a charter school, and I spent 10 years in a pediatric skilled nursing facility. So while my primary location has never been for a length of time or continue to be primarily a school, I have worked in a school. I do know where these kids are coming from and where they're going to. And this will be a really important point of view to share when we begin to talk about community connections and collaboration with outside professionals. I also, as I stated, am a practicing clinician and a clinical assistant professor at Marquette University. So we are so excited to be presenting this today because this isn't just for speech language pathologists. This is for speech therapists, occupational therapists, physical therapists, special educators, regular ed, paraprofessionals, administrators, nurses, and nutrition team members. And I am so excited to have all of you here. So I am assuming that we've covered everybody here. Is there anybody here that we didn't cover? Throw it in the chat. If you have individuals like this who are working in your school and whom you think might be interested in hearing this, we are recording it, and this is going to be an ongoing series for the entire rest of the school year, which is very exciting. And I won't be the only one to be speaking, so you don't only have to listen to me. We're going to be bringing in a wide variety of all of these team members to have them give you their perspective on this very important topic. Just out of curiosity too, if you want to throw it in the chat, I'm curious if any of you are doing feeding and swallowing in the schools. And if you are, what district or what school are you in? I know Dawn would love to see some of that information, and myself too, because you as well are experts in this. So a little bit of fact finding here. Each year in the United States of America, more than 120,000 or 1 in 33 babies are born with a birth defect. This is from the March of Dimes. They have not updated this for a number of years. I did go back and check. 2019 is their most recent data. The preterm birth rate declined 1% from 2021 to 2022, which was a fantastic thing. And then it went up again to 10.4%. So we see racial and ethnic differences in preterm birth rates that remain high. In 2022, preterm birth rates among Black women were 14.6% and was about 50% higher than white or non-Hispanic individuals. And Hispanic women had a preterm birth rate of 10.1%, and that's directly from the Center for Disease Control. So as it is not surprising to you, we are a first world nation that has some truly third world nation statistics in terms of our birth rates. What is astonishing to me is the medicine that has followed these infants. So I started working out as a therapist in the 90s, and I remember hearing about infants that were born at 26 weeks gestation and just thinking, wow, that is amazing. And 20 weeks gestation isn't even the edge of viability now. We are definitely seeing 23 and 24 weekers and even 22 weekers. So we have the medical technology in place that continues to help these infants to survive and to thrive. And it's not just our preterm infants. So an estimated 9.2 million children annually, when we think about childhood injury, had an initial emergency department visit for an unintentional injury. This includes head trauma from falls, car accidents, firearms, choking, and near drowning events. This does not include medical conditions such as seizures and cardiac arrest, which we know, again, we have a significant amount of our population that does have other medical conditions that they are surviving with and thriving with. So when we think about disabilities in the schools, in the 2022-2023 school year, 7.5 million students in the United States received special education services, which is approximately 15.2% of the public school population. The most common disabilities among students receiving special education services included SLD, or specific learning disabilities, which was 32%, speech and language impairments, which was 19%, other health impairments, or OHI, which was 15%, and autism, which was 13%. And as you know, many of these and other diagnoses impact a student's ability to safely and efficiently consume nutritionally balanced diet. So I think that more and more we are becoming aware of this topic and we are able to identify it. But we've been looking at it as school practitioners are saying, so what is my role in all of this? Well, eating is a lifelong skill, and no matter where you work, you may directly or indirectly be involved with children who have feeding and swallowing disorders, yes, even in the schools. And several years ago, it's been a little bit of a while now, the American Speech and Hearing Association, who as speech pathologists is our governing agency, put together something called the Guidelines for SLPs, providing swallowing and feeding services in the schools. So this is something that I think speaks to the fact that this has come to the forefront of our practice, and we are having some questions. And so our regulating agency said, hey, we have some information we want to share. And I know that other agencies who oversee occupational therapists, who oversee nurses, who oversee paraprofessionals, all of those, you all have similar information that you can refer to. So what is the history of feeding and swallowing in the schools? Well, prior to 1995, the provision of swallowing and feeding services was really not part of the workload in the schools. We know that all of us as practitioners have continued to evolve. Think about things that we used to do that we no longer do, and think about things that we're currently doing that we never used to do before. So this increased incidence and prevalence of pediatric feeding disorders, or PFDs, has resulted in the need to expand school-based practitioners' scope of practice to include evaluation and management of feeding and swallowing. And again, I want to state that this is not just SLPs. This is the school-based practitioner. This is all of you, very important team members. One of the things that we talked about when we formed this work group about 2 years ago was that I feel very strongly, especially for our paraprofessionals, and I hope there are some paraprofessionals here online today, and if not, invite a paraprofessional and tell them to invite a paraprofessional, because some of them are our frontline workers who are with these individuals day in and day out, sometimes assigned one-on-one to these young children and young adults, and they are vital to be included in this information. So the increased incidence, prevalence, and identification of pediatric feeding disorders, or PFDs, in the educational setting has resulted in not only the need for expansion of the traditional speech or occupational role in the schools, but also the development of these procedural guidelines, interdisciplinary role delineation, so who is doing what, and the development of the foundations needed to establish safe and efficient meal times at school. So I think in the past a lot we went, that child isn't safe to feed. Maybe the nurse would come and hook them up to their feeding tube, or a paraprofessional may be trained in that. And we just let them be in their chair, in their space, and receiving their tube feeding. Well, we know that there's been a lot of changes, not only in the tube feeding equipment, that makes it safe for children to actually be fed day in and day out in their environment while they're moving around. They don't have to just be seated most of the time. We also know that a lot of these kids actually can do multiple things, such as, say, take tastes, or maybe hold and explore food in a safe manner that allows them to be included. And that's huge for all of our children, is that idea of participation. So we do, though, want to differentiate between medical and school-based services, right? And there is a very clear line. There are also some blurred lines. So medical services obviously occur in a hospital or an outpatient setting, or even within the home. They can be acute or longer term and are consistently ongoing. Medical services and their team members have access to other team members and medical equipment for procedures. Speech therapists and occupational therapists, along with other professionals, have a high caseload of feeding and swallowing disorders and likely more refined skills. I can tell you myself as a practitioner, the private charter school that I did work at hired me specifically when they did because I had such experience with acute children. Medical service providers are also responsible for the assessment and diagnosis of these pediatric feeding disorders and subsequently are responsible for determining appropriate safe diet and other feeding recommendations. So let's compare that to our school-based service providers. In the schools, you are likely limited to the school building and the school day. This is longer term until the age of 21, and then there's breaks due to summer or holidays or even movement between schools. We know that there is a lot of transitory pieces to some of our families and even within districts to schools within some of our families, especially those who may have concerns for housing and are moving quite regularly. From a school-based service standpoint, we need caregiver permission to access the medical team other than your school nurse. And the school-based service is really responsible for the identification of students with feeding and swallowing disorders or who may be at risk with the referral to the medical team. And I highlighted that, bolded that, because again, I want to make it very clear that we are not here today to tell you effective immediately, you have to start providing speech and language and feeding services in the schools. We are here to say that this is a team service and that we want to support you in understanding how this can be implemented. We think it's so important that we are thoughtfully presenting this over 9 months of information. And one of the things, again, is that the school-based service practitioner is responsible for the implementation, again, bolded there, of a medical team plan. So we don't expect you to take a child who's aspirating or a child who may be at risk for choking and say, okay, well, I think this is what we should do. No, you are a member of a team within your school and you are a member of a larger team within the community, mostly being, again, those who receive medical services and who can provide that information for you. So when do we see these individuals in the schools? And I apologize that this control panel, again, I fear if I move it down there, then I'm going to block the closed captioning. So I'll just kind of unhide it here for a second. Why do we address feeding and swallowing in the schools? Well, children with feeding and swallowing disorders may experience more chronic illness, resulting in more missed days of school. And we know that that obviously can impact them from a learning standpoint. We know that children who have feeding and swallowing disorders have nutritional needs that may not be adequately met, which impacts growth and development and especially attention. Now, I'm going to be honest. I tell myself that my husband is a camel. He can go all day without eating and come home and eat all of his calories in one sitting in the evening. However, I'm also going to be honest with you and saying he's hangry at the end of the day. And he comes in and we really can't talk until he's eaten. Our kids can't do that. They really do need multiple opportunities to eat. And some of our kids even will need multiple opportunities outside of breakfast, snack, lunch, snack. They might even need more snacks within there. We have individuals who are at choking risk, and it's very important that we understand what their choking risks are. And really overall, again, for all of our students, participation is impacted. It may take longer to eat and require special space away from peers. Now, for some of our kids, that special space away from peers is really best practice. For example, think about some of our children with autism who have very, very strict routines. They require a specific space. They require an absence of sound or other distractions. They require only their foods and cannot be around other individuals' foods, which from a olfactory or smell standpoint or even visual standpoint may turn them off into their own foods. So again, that might be best practice for some of our kids. But in general, we want all of our kids to learn how to participate in mealtime within an environment where others are eating. So again, I'm going to uncover this here. So students with feeding and swallowing disorders, they may have their weight and nutrition be affected by delays or disorders in the development of eating and drinking. And we know that weight is directly correlated to brain growth and development, right? Some of these individuals in the schools may need special equipment for eating. Some of these individuals, as I just talked about an example of, may have sensory concerns, and some of them may even need someone to assist them with eating at school. Again, this is where our general ed, regular ed, and paraprofessionals come into play, and that you have those moments every single day, multiple times per day, helping these individuals to eat. And we're going to have some presentations coming up where we talk specifically to you, and we talk about some tips and techniques, and thinking about how fast do you feed somebody? How slowly might you need to feed somebody? What other distractors might impact when you're feeding somebody? We know you're busy. And so the point of this is, again, to support you in supporting the students whom you service. Okay, so let's just start here. First of all, we anticipate that there's a wide variety of knowledge on this subject. So I want you to think for a minute, what do you know? What do you know about feeding and swallowing in the schools? Again, maybe you're not doing this. And if you have some things that you know, maybe throw them in the chat. A big question that we have, and I hope to see the chat explode right now, is what do you need to know? Or what do you want to know? Because again, this can help us to drive our presentations. We know what information we want to give you, but if we can catch some of the nuances of what you need, that's my job here, to support you in that. So just go ahead and think for a minute. What do you know? What do you need to know? And start filling up that chat. I'm seeing a couple things pop in there. I'm going to give you just a minute to think about that. If you're with a group of individuals, maybe you're watching this within your school, maybe you're watching this as a team, have a chat for a minute, talk about it, think about this, or take this as a question and bring it back as a morning discussion. So seeing that chat fill up, great. All right, so let's just start with some basic definitions. We're going to talk about feeding versus swallowing and dysphagia. And then we're going to talk about a consensus of what pediatric feeding disorder, or PFD, is. Now, for those of you who haven't heard of pediatric feeding disorder, it may be because you haven't worked in this area, and that's okay. For those of you who are like, well, wait, I work in this, I haven't heard of this, it's relatively new. So I want you all to feel comfortable in recognizing that we all have different knowledge, and what I share with you today might be new, and that's okay. So let's define feeding. Feeding itself is the process of consumption of nutrients and fluids for growth, nutrition, and hydration. Feeding is a spontaneous and natural process, and feeding is completely dependent to independent in its progression. So think about a newborn infant, right? They will spontaneously go to breast or bottle for feeding when presented. We all know about the reflexes that if they're hungry and you stroke their cheek, they will turn to it. Again, Mother Nature set this up for success. It is completely dependent upon a caregiver to feed a newborn. We have to hold them, we have to present whatever the feeding device is, whether it be breast or bottle. And as infants grow, they become more independent. And that independent progression is very exciting. We start to see them open their mouth when they see the bottle. We see them start to open their mouth when they see the spoon. We see them start to grab for the spoon. We see them take that bowl of food and dump it all over and get their hands in it, till eventually you have somebody who is feeding themselves finger food and learning to use a fork and a spoon and even a knife. So this here is the feeding stages. So early feeding happens from birth to 6 months. Birth to 6 months, again, is that stage where we are looking at breast or breast and bottle. Some infants will be introduced to purees or early solids at this point. And then we transition into what's called the complementary feeding or transitional feeding period. So during the complementary feeding or transitional feeding period, which happens from about 6 to 9 months when we're introducing purees and soft dissolvable solids, think about all those little star puffs that the babies eat now, and 9 to 12 months as they get into some of those early table foods, and then into those toddler foods. Beyond that, we're looking at school-age kids and typical adult eating. So swallowing is different than eating. Swallowing or feed is different than feeding. Swallowing is the process of moving the food from the mouth to the stomach. So I'm going to just press play on this.
Swallowing consists of the safe transport of saliva, solids, liquids from the mouth to the stomach. This complex mechanism requires the coordination of the mouth, pharynx, larynx, and esophagus. Each second requires the work of 31 muscles. Swallowing consists of 3 different stages. During the oral stage, the food is taken into the mouth and stimulates the different taste organs. The food is chewed on and wrapped in saliva to form what we call an alimentary bolus. Once the portion is ready to be swallowed, the tongue propels the bolus towards the pharynx. During the pharyngeal stage, the bolus arrives in the throat, which triggers the swallowing reflex. The epiglottis folds down to close the larynx to protect the respiratory tracts and to allow the bolus to travel from the throat to the esophagus. The esophageal stage is characterized by the passage of the bolus from the esophagus to the stomach thanks to the relaxation of the upper esophageal sphincter.
So that's just a nice little introductory video there to sort of give you a preview of what I'm going to talk about now in the next couple of slides. So as that video showed you, there are 4 phases to the swallow, okay? And each of these phases is unique and different. So we have the anticipatory phase, the oral phase, the pharyngeal phase, and the esophageal phase. Now, for those of you who are online, and this may be, again, new anatomy and physiology to you, when we're talking about oral phase, we're talking about the oral cavity or the mouth. When we're talking about the pharyngeal phase, we're talking about really the throat. And when we're talking about the esophageal phase, again, we're talking about the esophagus or that tube that gets the food down into your stomach. So let's start by talking about the anticipatory phase. The anticipatory phase is the preparation before eating. This is when hunger is stimulated. So for those of you who celebrate Thanksgiving, I always think this is a perfect example of the anticipatory phase. You walk in Aunt Edna's house and you hear the football game on in the background. You smell the turkey in the oven. You see the dinner plates are set and the pies are sitting on the oven. You can smell everything. You can hear everything, the clanging in the kitchen. This is all the anticipation of food is coming. If you're anything like me, when it comes to Thanksgiving, I'm excited for a lot of food to be coming. This sets the stage for eating. And it's all about the sights and the smells. After we get through the anticipatory phase, we get to the oral phase. So the oral phase has 2 stages. The first is what's called the oral preparatory stage. These are voluntary movements, and that's a really important point because you have control over this. You are moving your mouth, your tongue, your teeth, your lips, all of this to chew the food until you feel like you're ready to swallow it. And if you think about it, I'm quite certain that most of us, if not all of us, have had that experience where you're in a rush, You're chewing, chewing, chewing. You're like, I'm going to swallow. And you go to swallow and you're like, wait a minute. I did not chew that food well enough. I better keep chewing it. And so you kind of like push it forward in your mouth a little bit, chew it some more, and then you swallow it. You're being safe. You're preventing yourself from coughing or choking, gagging. So this oral preparatory stage is when food is chewed and mixed with saliva to break it down and prepare it for the swallow. Food and liquid in this stage is gathered into what we call a bolus, or a really fancy word for ball, on the center of the tongue. So let's take a look at this animation. There's no sound with it, so you're not missing anything. So the food enters the mouth, and we begin chewing. And you notice how the tongue moves the food from side to side. The jaw is moving in this rotary movement and creating this ball of food, which then sits on the center of the tongue and is pushed back for a swallow. So then we move into the oral transport stage, which is when the movements are still voluntary, but again, the tongue propels the bolus, or that ball of food, into the back of the mouth. So now let's get into the pharyngeal phase. The pharyngeal phase begins with the triggering of the swallow reflex. So if you remember on my previous slide, I said that voluntary movements were still present. Well, this is now when movements become involuntary. So again, you know, if you started to swallow something, like it's pretty hard to get yourself to stop swallowing because this is a reflex, right? And that tongue drives the bolus backwards. It says, hey, food, let's go back, let's get out of the mouth. Now, the swallow reflex is really important because it causes 4 physical, really neurological in our brain events to simultaneously occur. So these 4 events occurring at the same time are really important for us to understand because this is what keeps us safe. So the first thing is that the soft palate, and if you all can take your tongue for a minute and find the hard palate on the roof of your mouth and go all the way back, you're going to find your soft palate. Another way to find your soft palate is to look in the mirror and say, ah, and you see your uvula hanging down. That's the tip of your soft palate. So that piece of muscle elevates, and that prevents food from going into your nose or into your nasal cavity. The vocal folds or vocal cords close to prevent the ball of food from entering into the trachea or the windpipe. So what happens is we have a windpipe or trachea and our esophagus, which run parallel to each other. This is all very quickly timed. And so we have to make sure that we're staying safe and preventing food from going down the wrong pipe, which we've all said, right? Oh, the food went down the wrong pipe. You usually say that when you've been coughing. Coughing is protective. The food started to go into your airway and your body said, nope, wrong way, get it out. The next physical or neurological event that happens is what's called initiation of pharyngeal peristalsis. It's a really big word for saying that the muscles squeeze the food down. Again, if you've ever taken a bite of food that's too big or swallowed something that's very dense, you may feel that movement of the food going down, and you might even kind of touch your chest and go, oh, I could feel that. You're feeling your pharyngeal peristalsis. And then finally, we have relaxation of a muscle. It's a really fancy named muscle. It's called the cricopharyngeus and allows that food to go into the esophagus. So these 4 neurological events should occur simultaneously, but they don't always. And again, the population that we're talking about here may be kids like kids with autism who have more selective feeding. But think about our kids with cerebral palsy or any other neurological event, even kids with Down syndrome, seizure disorders, where this may not happen and helps to prevent or just basically prevent somebody from eating safely. So then we get into the esophageal phase. So the esophageal phase is when food is pushed down into the stomach by those peristaltic or wave-like motions of the esophagus. I'm going to apologize right now. My dog is barking in the background. I thought I gated her out as far as I could. Next time we'll do better. So after we get through all of these 4 phases, we want to talk about what is dysphagia. So anytime you see the word DYS in front of something, it means poor, and phagia means swallowing. So dysphagia is an impairment in the ability to chew or swallow food or liquids. So this is probably what you're most commonly aware of, dysphagia, this inability to safely or efficiently chew or swallow food or liquids. Dysphagia can lead to what's called aspiration. And aspiration is when food or liquid enters the airway or lungs. And this can cause infections, otherwise known as aspiration pneumonia. So I'm going to show you 2 videos now of a swallow study. And the first is a normal swallow study. I think they're pretty cool. It's a moving x-ray of this individual swallowing. They are chewing some food with barium in it. And you can see where the food goes down the right way. So let's take a look at that. I'm going to try to make it big here. Oh, it won't let me. So see how that food just goes very clearly down? Boom. It's a nice, even way that that food moves. Very quick, efficient. On this one, you're going to see food go towards the back, but you're also going to see some food spill over into the front. Look carefully. And there it goes, right there. All of that liquid that's going towards the front, I'll let you watch it again, is aspiration. And that basically, in this case, this looks to be a liquid, is liquid going very quickly directly into that individual's lungs. Okay, so going on to talk about dysphagia, why do typically speech language pathologists and occupational therapists work with dysphagia? Well, we have a knowledge of anatomy and physiology, and specifically that anatomy and physiology of the oral, again, our mouth, pharyngeal, our throat, and laryngeal, which is the larynx is where your voice box or your vocal folds are contained mechanism. And this, again, is all part of the safety that we know happens when we swallow. Many people with dysphagia also have communication disorders, and so we know that there's that overlap in our scope of practice, or they have impairments in daily living or self-feeding skills. So we've all seen little kids learning to eat, and that can be messy, and it takes a while to learn that. But we also have individuals who need some sort of adaptive eating or adaptive feeding. So let's take a little look at this video here quickly.
I did get very frustrated, so political state of me, but that was a really good.
Okay. And that individual there was having some help with wiping the food, but also was having help with feeding through a special utensil. Right. OTs especially, our occupational therapists, have this knowledge and skills in the sensory components of mealtime. So I had here, and I'm gonna skip it for time's sake, a video of individuals eating lunch at school. And when you think about individuals eating lunch at school, think about how noisy that environment is. Think about how crowded that environment can be. Think about how chaotic it can be with kids running around and somebody's crying and somebody spilt milk and I don't like this and will you switch lunches with me? There's a lot going on. And this can be very overwhelming for anybody who's in the lunchroom in general, not to mention any of our kids who have any sort of sensory components to their makeup. So let's get to that definition of pediatric feeding disorder, or PFD. So PFD has 4 domains. And these 4 domains determine this impaired oral intake that is not age appropriate. That's really important, not age appropriate, and is associated with medical, nutritional, feeding skill, or psychosocial dysfunction. So conservatively, we know that pediatric feeding disorder affects more than 1 in 37 children under the age of 5 in the US alone. That's a huge statistic. And for these kids, literally every bite of food can be painful or scary or even impossible. And this impedes nutrition, development, growth, and overall well-being. So I want to introduce you to a young lady named Lucy. And this is a video from an amazing organization called Feeding Matters. Feeding Matters is one of the organizations that supported the team that put this consensus paper together. And this consensus paper was really important for us because not only did it give us a code for billing this, but also a way to bill for reimbursement. So let's go ahead and meet Lucy right now.
Hi.
Lucy's personality is intense. She is high functioning, she's happy, she's always laughing, and she's polite. She is very funny. She has the most beautiful eyes.
These are big fish.
I also love how spunky Lucy is, how energetic she is, and she is adventurous. She just will try anything. She's this light that I'm sure is meant to be out there to inspire others. Our favorite activity is the zoo. Lucy likes to go to the lions, and when the lion growls at her, she growls back.
The zoo is wet and black.
Show me. Yeah, it's your tummy. We're at the zoo and we're feeding her through the button. We'll get the looks, and if people say, "What is she doing?" we just simply say, "Oh, that's how she eats." Okay, this much more. So around 6 months of age, we started to introduce solid foods. We started with rice cereal, the typical mixed with formula. Her reaction was not good. And the very first time we tried it with her, she screamed, and we couldn't calm her down until we wiped it out of her mouth. We talked to the pediatrician, and she said, "Don't worry about it. It's very typical. She's probably just not ready. Give her 2 weeks, try again." So we did that, and we got into that cycle. Wait and see, wait and see, wait and see, and we were waiting and seeing at 14 months. That's when she went into the hospital with a respiratory infection, and that's when they placed the tube to feed her via her nose into her stomach. I knew what a feeding tube was. I had seen one, but I didn't think that my child was going to need one. She didn't have any major medical problems. At that time, she was virtually taking nothing via bottle. It was all via tube. I was the one responsible for replacing it when it came out. It came out if she tugged on it. It came out whenever she vomited. It was just vomiting every day, sometimes several times a day. Whenever she'd bonk her head or get panicked, she'd vomit. The act of her seeing us eat would make her vomit. We were in therapy, but therapy wasn't able to be effective because of all the vomiting. I got to hold her down. I got to lube it up, put the tube in, put a stethoscope on her stomach, inject some air, listen for the placement to make sure it was in the right place. All the while, this little tiny girl is just traumatized by me, the one that she's supposed to be able to trust to keep her safe and to keep her free of pain. I couldn't do that to her anymore. And that's when I just said, if she's going to continue with tube feeds, then we need to switch to a G-tube, because this is not a life for this little girl. This is not how to grow up. Life was miserable. We dreaded every meal. I dreaded because it would end up in me getting angry and taking the plates and throwing them into the sink. Garrett and we've fought a lot. And it was usually in relation to Lucy. We had to find something. And that's when our searching began and ultimately led us down the road to Feeding Matters. I was able to find some resources outside of our state on Feeding Matters website, and when I contacted those people, they were actually interested in our family and in helping us. That was a day where we were just really happy because we saw some hope. In our relationship, we needed that lift, and we got it, and things really started to improve. I knew it was going to work after I spoke with Chris at Feeding Matters, and we got our new doctor to prescribe the medicine.
and the vomiting stopped, that's when we knew we had it. We worked with the therapist on the phone for probably 4 or 5 weeks, and the first tip she would give us is regarding the blend, her recipe. And the moment we implemented the tip that she gave us, we saw an instant improvement. Okay, go slow. Ready, go. Then we traveled to Tucson, Arizona, and spent 5 days in a hotel room doing nothing but therapy. First day of therapy on the new therapy method, and Lucy took a drink out of a cup through a straw. It was just water, but it was the first time she had had water like that in over 3 years.
Now, mealtimes, Lucy is a joy to sit with other people. She loves to point out the different colors and the different sauces, and let's learn what all these new foods are.
Lucy has no medical diagnosis. That's still hard for me, but we absolutely left that therapist with all the confidence in the world to continue what we learned with her, and that was to really be able to enjoy mealtimes as a family. And someday soon, we're just hopeful that that mealtime for Lucy is going to be.
I can go back here and get to where we were. Okay. So that video is very powerful. I've watched that video. I use that video for teaching. I've watched that video probably 20 times. And every time I watch it, it gives me chills. Really, because it shows the family side and the impact on that child of just participating in a daily routine of eating. So what can cause PFD? There's medical concerns, things like GI issues, reflux, respiratory or heart issues, neurological impairments, neurodevelopmental disorders such as autism. From a nutrition standpoint, we see individuals who restrict the quality or quantity or variety of foods. And from a feeding skill standpoint, we see individuals who have oral motor functioning, meaning that their mouth cannot move in the way it should, oral sensory functioning, meaning that individuals cannot safely feel or tolerate the feel of food in their mouth. And this also includes unsafe oral feeding, so individuals who might be aspirating, delayed feeding skills, or inefficient oral feedings. And we all know those kids who take long to eat, but this is beyond long to eat. Psychologically, we have individuals who have learned feeding aversions, who suffer from stress or distress, disruptive behaviors, what we call food over-selectivity or picky eating, and the use of inappropriate strategies by caregivers, such as take a bite, I'll turn the iPad on. So students most at risk in the schools, up to 90% of children with autism spectrum disorders may have PFD. Up to 80% of children with developmental delays may have PFD. 26% of premature children, and somewhere between 19 and 99% of children with CP. The rates increase in that population with greater severity of cognitive impairment and decline in gross motor functioning. So the more involved they are, the less likely they are to be a successful feeder. And then 50 to 80% of children with Down syndrome. So what are the effects of PFD? Well, there's respiratory complications. We've already talked about aspiration pneumonia, malnutrition or dehydration. Again, that reiteration of impact on growth and development, and that's brain growth and development. We're in the schools. We're here to have children learn. And the emotional consequences, thinking about that decreased enjoyment of eating or socializing. And for some of our kids, even it can be a fear of choking. And as you saw in that video, there's that stress to the family and caregiver. So one thing that we want to introduce to you today briefly in the time that we have left is what's called the ICF, or the International Classification of Functioning, Disability, and Health. And the ICF is a classification of health and health-related conditions for children and adults, which was developed by the World Health Organization and published in 2001. This framework is used by interprofessionals across the world in a collaborative practice in person-centered care. So there's a lot of information on this slide, I know, and I want to break it down just briefly in that we look at two big pieces. The first is functioning and disability. Functioning and disability includes our body functions and structures. So this is the actual anatomy and physiology and psychology of the human body. And then we look at activity and participation, which describes their functional status. How do they communicate? How do they move? What are their interpersonal interactions? How do they care for themselves? How do they learn? How do they apply knowledge? Contextual factors are twofold. One being the environment, factors that are not within the person's control, such as family, work, government agencies, laws, and cultural beliefs. And then personal factors, which is such as race, gender, age, educational level, coping styles, etc. And we don't really specifically code these because of the wide variability, but they are included in the framework because it's important for us to think about. So here's an example of the ICF model written out. Here we have the disease or disorder and whatever activity they're doing. It's all impacted upon each other. And you can see the multimodality levels of this, where the disorder impacts the activity through the body's functions and structures, which then impacts their participation. And we have these outside environmental and personal factors, which can come in and also impact the activity. So for example, if you had a feeding activity, say you had a individual who had full-term infant, everybody was healthy, typically developing, and these kids are eating well. They can safely eat, they can efficiently eat, and they have typical skills. But then we compare that to a child with a health condition and look at all the red boxes that come up and how that again can impact that participation in mealtime. So intervention for us is going to need to address the impacted areas, and remembering that in all of this, the family is the most important team member, and student if they're old enough and depending upon their cognitive awareness. So we're going to get into, again, some of this in future presentations, but I think it was nice to touch upon that idea that intervention is going to touch upon one or all of these domains which are impacted. So I have a little case example here, and I think we have just enough time to do it. Carlos is a kindergartner with Down syndrome. He has a repaired heart defect that required long-term hospitalization and oxygen when he was an infant. Due to being in a medically induced coma for surgery and recovery, he required a gastrostomy tube or a G-tube. He is now able to successfully eat soft solids, graham crackers, and purees or pudding. When he drinks his prescribed formula, his mother and grandmother become very scared that he will choke. They often use his G-tube for fluids instead of his mouth. Carlos is a very social child and likes to imitate his peers. He is in a classroom with a teacher and one paraprofessional. It is a moderate-sized class, but there are two other peers in the room with significant needs. They both have autism. He eats breakfast, lunch, and snack at school. He has an IEP and receives multiple services, both push in and pull out. So think about this for a minute, and let's just throw it in the chat. What are some medical, nutritional, feeding skill, and psychosocial? And what are some other concerns that we have related to his participation in the school day? And I think Dawn can throw out some of the answers that she's seeing in the chat there since I have it hidden. So thinking about those four domains, medical, nutritional, feeding skills, psychosocial, and what I'm going to do is go back a slide. If I can, well, maybe I can't. Okay.
Jen, one of the entries into the chat is that there would be a concern of interaction with peers during mealtime.
Mm-hmm.
And are the parents' fears founded in actual aspiration or lack of experience and practice?
Yeah, those are great, right?
And the next one that came in is, if he has a good appetite, he could potentially grab other students' thin liquids and drink them.
Yeah, he could grab other kids' food, right? So medically, we know that this child has a complex history. From a nutritional standpoint, he receives a supplemental nutrition, the Pediatric, and his feeding skills only support things such as soft graham crackers and purees. And from a psychosocial standpoint, he has caregivers who are quite afraid of him eating, and they show that to him by not letting him eat, by talking about him and being scared of him eating, and by instead using his G-tube. And then we have this vivacious little guy who's in a classroom with a lot of peers and wants to interact with them. So you all hit upon some of those major pieces there that could be of concern to us. So we have here a list of references and resources, and exactly 5 minutes, which was what I wanted, so that we could go ahead and answer some questions. So I think at this point, Dawn is going to stop the recording.